to begin. My name is Lisa Moycambo, and I will be today's moderator. I would like to just start off with a little bit of background and welcome you all today. Good morning, good afternoon, good evening. Thanks for joining us. This is the first, actually, in the series of the Challenge Initiative's AYSRH Office Hour webinar series. And so I wanted to give you just a little bit of background. The Challenge Initiative is a Bill and Melinda Gates Foundation funded initiative aimed at sustainably scaling up evidence-based approaches to increase use of modern contraceptive methods among all women 15 to 49 years of age in urban poor areas. Although our goal is to increase contraceptive use among women and adolescent girls, we are involving men in our interventions too, in particular as it relates to AYSRH programming. Boys are crucial players in improve agency in condom negotiation skills and use. Adolescent and youth sexual and reproductive health programming was added onto the TCI platform in January 2018 and officially launched with a Master Trainer of Coaches and Trainers workshop in Kampala in March 2018. We know that one-off workshops and trainings are not enough, so we've invited implementing partners and experts in AYSRH to share with us more detailed knowledge about evidence-based AYSRH programming in a number of areas. Today we will focus on engaging men and boys in sexual and reproductive health, particularly family planning or contraceptive use. Involving boys in AYSRH programming can have a positive effect into adulthood, promoting critical reflections on masculinity and gender equality, as well as health prevention and seeking behaviors. Despite the literature emphasizing the importance of involving boys and men, they are often overlooked in traditional sexual and reproductive health programs. In today's webinar, the presenters will describe the different needs and programming considerations when working with young men, provide examples of evidence-based interventions, and share programmatic results related to outcomes as well as considerations for scale. I am pleased and excited to introduce you to today's speakers. Dominic Shattuck is the Senior Research Officer at Georgetown University's Institute for Reproductive Health. His work reflects his commitment to push the rigor of public health interventions and the conversion of research findings into meaningful policies. His work is informed by professional experiences where he facilitates adolescent and adult learning on topics including social and gender norms, HIV prevention, and reproductive health. Built on the belief that the inclusion of men's health services should be seen as complementary to women's health priorities, Dominic has championed the inclusion of men and boys in reproductive health services. His advocacy for men's and boys' inclusion in reproductive health was supported by projects where he coordinated the implementation of vasectomy services and monitoring systems, developed research articles, blogs, and presentations, as well as established channels for interpersonal advocacy among donors, government officials, and other public health professionals. Currently, Dr. Shattuck is co-chair of the USAID-sponsored Male Engagement Task Force and co-chair of the Male Engagement section within the International Conference for Family Planning. Our second speaker is Tim Shand, Vice President of Advocacy and Partnerships, Promundo US. Tim has worked to strengthen the engagement of men within sexual and reproductive health at the program, research, policy, and advocacy level for over a decade. Tim previously served as Deputy Director of the USAID-funded Passages Project at Georgetown University's Institute of Reproductive Health, where he worked to promote normative change, including positive masculinities, to enable adolescents to access modern family planning information and services. Tim previously served as Director of International Programs for a South African NGO, Sanke Gender Justice, and has also worked with International Planned Parenthood Federation and the World Health Organization. We're very excited to have Dominic and Tim join us today and share with us their experiences. I just want to go over quick logistics. Each speaker will have about 20 minutes or so. Then we will, while they're talking, we encourage you to ask questions by typing them in the chat box where you're currently introducing yourselves. We will collect those questions, and as many as possible we'll try to address before the end of the webinar. As I mentioned, we have a pretty full agenda, so for those questions we might not be able to get to, we'll make sure to collect and provide written responses when we circulate the webinar recording later this week or next. So thank you so much for joining us, and I'd like to turn the mic over, if you will, to Dominic.
Good morning or afternoon and evening to the listeners. It's really my pleasure to present to you today, and I'll briefly describe some lessons learned about male engagement and the reproductive health life cycle. That'll include the Grow Up Smart program, which focused on very young adolescents in Rwanda, and then some innovative programming for young adult men aged 20 to 24 years old. Almost across the board, men have poor health outcomes. Men are not good about seeking care, and often when they do, they arrive at the door only after their condition is significantly progressed. Thanks in large part to small slices of donor funds, public health experts have developed resources and guiding materials to integrate male engagement interventions. In an exciting turn of events in the last month, the WHO started to commit is committing to focus on the impact of masculinities in some settings. And I anticipate that this is a turning point for men's health, particularly as we consider the sexual and reproductive health impact that it has on women. This list was created by my colleague, Rebecca Lundgren. Her lessons learned highlights the importance of recognizing diversity within your target group. This includes men's range of wants and needs, their roles in their households, and emotional preparedness for change. These factors shape interventions, and it's important to recognize that my presentation, it will describe more heteronormative interventions. So whether your project is working with a group of cis, gay, or transgender men, as Rebecca suggests, the men won't arrive at your intervention with the same history. Diversity exists in all groups. Also, underlying much of the male engagement work are social and gender norms. Identifying and understanding these norms in the men's normative reference groups are critical to programming behavior change interventions. You may be familiar with images like this one. I've added a couple categories to the life course, and those are older adolescents and single young adults. I added these groups because male engagement programming is beginning to differentiate the way in which health information is being delivered. Tailoring activities for age groups by managing the volume and complexity of information is using good pedagogy. Programming should acknowledge that relationships evolve with age. We imagine that romantic relationships at 14 are probably much different than at 23 years old. And this life course graphic, one thing about this life course graphic is that it doesn't explicitly include all sexualities. Over time, I hope to evolve this graphic toward that goal. And if you happen to have any access to more inclusive life course graphics, please share them because I think it's desperately needed in our field. Like women, men have different needs across their reproductive life cycle. Utilizing graphics like this facilitate considerations of connections to men's other health needs and changes over time. Often gender norms influencing men's behavior are considered barriers inhibiting women's access to contraceptive methods, or they're attending maternal and child health care services. Family planning program can and is doing more to consider opportunities for male involvement as part of a couple or supportive partner, and sometimes as users within particular reproductive health needs. So I'm going to move into the Grow Up Smart project that was implemented by AYSRH and partners in Rwanda and discussed its implications for interventions with boys. The Grow Up Smart intervention sought to improve the sexual and reproductive health knowledge, attitudes, and behaviors of very young adolescents 10 to 14 years old in Rwanda. And I'll give you a somewhat brief snapshot right now, and there's a manuscript forthcoming. The intervention was a combination of puberty education games and some reproductive health materials. The GUS team developed a variety of resources, including facilitator manuals, brochures, and storybooks. These tools matched an interactive learning style for very young adolescents. When implementing activities, the GUS team used both sex-segregated and then sex-mixed approaches. This means that some sessions were conducted with boys and girls separately, while others asked boys and girls to participate in the activities together. Girls were also provided the Cycle Smart kit that included cycle beads, calendars, and reusable pads. To assess changes in participants, a longitudinal cohort study was followed. Unfortunately, there was not a control arm, but we do have a large sample of almost 1,400 boys who participated, who provided data pre and post intervention. Today, I'll present only on boys' data, but we do have a slightly larger sample of girls who participated in the intervention as well, and they'll be included in the manuscript. The evaluation found that boys increased their knowledge about men's and women's reproductive health over time. These factors included information about the reproductive cycle, aspects of fertility, puberty, and sexual arousal. Looking at the distribution of scores on this slide, you can see the shift in the number of correct answers on this single question. AYSRH has been studying the role of fertility awareness across multiple projects. And within other projects, AYSRH has identified the association between increased fertility awareness and contraceptive uptake. This graph reflects changes in boys' scores on 2 fertility awareness questions. As you can see here, boys significantly increased their knowledge about the onset of fertility as well as the timing of the fertile window. When discussing gender, boys were asked 6 gender normative questions that were modified for very young adolescents. This significant increase in boys' scores reflected more equitable norms after participating in the Grow Up Smart intervention. As I'll discuss in a moment, general information is not enough. Programmers are pressed to address gender normative challenges, not only to reduce barriers to access for women and girls, but also to support men and boys' utilization of services and making solid reproductive health decisions. If they're comfortable with I kind of work on the philosophy that if men and boys are comfortable seeking health care, then it's reasonable to believe that they'll be less likely to oppose their partners seeking health care. We asked boys if they were comfortable talking with a trusted adult about romantic relationships and any physical changes associated with puberty. This is an interesting couple of graphs because we didn't see a big shift in boys agreeing with the statements. In fact, there was a slight reduction in their agree responses. This is an important finding to build on. Recall that over the course of the intervention, boys learned about both male and female reproductive health. Also recall that their mean age is 13 years old. So it may have been the first time these boys actually considered talking to an adult about these topics. And it's possible that this intervention may not be enough to facilitate those conversations. And these are tough conversations as an adult and also as a 13-year-old. And one question we kind of need to ask ourselves as programmers for adolescents around SRH is whether or not parents or trusted adults are actually prepared to participate in those conversations as well. From the Grow Up Smart project, we learned that utilizing a combination of sex-segregated and mixed-sex groups can help facilitate fruitful conversations within a collection of very young adolescents. Also, the marked increases in knowledge in children's more gender equitable responses reflect interest among VYAs to learn this information in a safe setting from a trusted resource. Last, although there were marked increases in knowledge for the boys' scores, what will come out in the manuscript is their scores actually lagged behind the girls. The girls' increases in knowledge were much higher. There's a great deal of work to be done on this topic, and making these messages increasingly relevant for boys is going to be important in the years to come to lay that strong foundation for their health decisions moving forward. So for the remainder of my time, I'm going to shift and describe some interventions for young adult men. And I'm going to start this with a small story that happened to me this last spring. One of my colleagues and I were in a rural village near Rapundahi, Nepal, talking with 5 young men between the ages of 18 and 21. After a while, and we were there doing our work and talking about access to health services and utilizing health services in their community. After a while, we asked them where they get their health information. And these guys said they would never talk about sex or reproductive health, family planning with their parents, or they would never go to the health center. And they would only talk to their close friends about sex or family planning and these topics. And thinking back to when I was their age, I don't know that it was all that different for me. My colleague and I probed and we asked a couple of questions about where they get their health information. And like a lot of us, where we get our information, they get it from Google. And yeah, so Google's a great way in which to answer a lot of questions. But as public health professionals, we need to learn more about how and what adolescents and young adults are learning on the internet, how they interpret it, and how they enact it in their lives. Some of this research exists in developed countries. There are studies on this topic in the United States for sure, and I think I may have seen 1 or 2 in West Africa. Also, we need to learn more about whether these young men can identify reliable and accurate information on the internet, or if they accept all information as accurate. Interventions large and small need to consider that beneficiaries are processing a variety of information about sexual and reproductive health. And they're also processing how it should be enacted in their lives. Before moving on to the interventions, I want to quickly return to the topic of diversity and provide some examples that you might run into when working with men. Marital status, employment status, education levels, specific risk behaviors. These may be necessary for you to segment your participants in your focus sites or your target audience of your beneficiaries in your interventions to address the needs of young men who are at greatest risk for the outcome of interest. One area that doesn't get much attention in our field is actually positive deviance. In other words, those men who are not taking risks or enacting risky behaviors. What can be learned from those men, and how can it be integrated into your program activities? This is something that we talk about often in our conversations around men, but we rarely see it explicitly integrated into the activities. One project that was focusing on young adult men is AYSRH's TJ project. This project focused on social networks to influence family planning use in several communities in Benin. Working through the social network helped to address the overall context in which reproductive health decisions are made and helped increase support for family planning use. Another recent male engagement intervention was Banda Barejo in Rwanda. I think Tim will kind of go into this in a little bit more detail, but briefly, this intervention worked with young fathers and their partners for 14 sessions that touched upon a variety of topics and utilized critical reflection and dialogue. Increased family planning use was identified in the results among several other positive outcomes. Currently, AYSRH collaborates with the TIER Fund to implement transforming masculinities. This intervention works in religious communities in Kinshasa and focuses on faith leaders and gender champions to address harmful gender norms related to violence. Another organization is MVP, and MVP strategizes. It's a US-based organization that provides gender violence prevention education. I included MVP because of their approach, which was developed from bullying curricula in the United States. This bystander approach utilizes vignettes and critical reflection questions that help personalize stories for men and women, influencing their decisions. So male interventions have to balance the short-term benefits of getting men into the actual project activities with other activities that truly transform harmful aspects of masculinity. Programs are designed to appeal to men's interests by using a variety of tactics, things like activities-based approaches, elements of self-monitoring, engaging men in friendly competition, and establishing safe spaces for men. Interventions have also appealed to men by being set in locations like soccer pitches, barbershops, and even I read about a couple in England that were focused in pubs. I might sign up for that one. Also, content utilizes language in the various settings that make men more at ease and allows them to affiliate the intervention with something they already like. But the challenge for program is to ask how their intervention transforms men's health behaviors. This will include challenging questions and providing men with a safe space to critically reflect on the value and the steps toward managing their health and relative behaviors. Programmers should find ways to lighten the atmosphere around this difficult conversations while providing men with the opportunities to practice those conversations about topics that many men have never discussed before. Activities should emphasize equitable communication and improve men's understanding of power and equity in their relationships. And personally, kind of a secondary goal that I think all of these interventions should have is to develop champions. Now, each man can be a champion in his own way, some more openly and outward and verbal, some within their own personal relationships and championing on a one-on-one basis. But I think that should be somewhat of a secondary outcome for many of these male engagement interventions. Thank you very much for your time today, and I'll turn it back over to Lisa and then Tim moving forward. Thank you.
Wonderful. Thank you so much, Dominic. We really appreciate it. As you can see, Dominic provided a number of links to references within his presentation, and you'll have access to those via the audio recording, but also we'll send out a separate note with all the resources, as well as invite you at the end of this presentation to an online forum space to continue the discussion. Uh-oh, someone made the chat window big. Okay, sorry about that. But here also are a number of the resources as well. And Dominic, one of the questions that was asked, since you did so well sticking to time, I wanted to offer at least this question. Anne asked, I wonder if the knowledge lag for boys is due to lower interest in what happens to female bodies than that of girls. Do you think that there could be an underlying reason?
I do think that has a lot to, girls understanding that menstruation may be on the horizon for them, very much could influence their interest in, in that topic and in those knowledge questions. But girls also had higher scores on men's reproductive health information as well. So it's kind of a double-edged sword. It's a situation where girls are performing better on these tests. And it may be also related to the way in which the information was relayed to them, giving girls a comfortable space in which they're able to learn safely, could be critical in influencing their uptake and retention of that information. So it could be a lot of factors, but definitely the reality that menstruation may be on the horizon for them could really influence their retention of that information.
Great, thank you. And please feel free to continue asking questions in the chat box, and we'll collect those at the end. Right now, we'll transition to Tim's presentation, which builds off of Dominic's and provides a number of additional evidence-based programs that have also gone to scale. So, Tim, I welcome you to the mic.
Great, thank you, Lisa and Dominic, and thank you everyone for joining. It's a great privilege to be part of this conversation. It's really important that we're talking about this issue, and pleased that TCI is doing so. I'm going to talk in particular about some of our programming on young men and young fathers and reinforce one of the key messages that Dominic has just been making about the importance of gender transformative approaches within our work around AYSRH. A word about us: we are working together to transform masculinities and promote gender justice. We just celebrated 20 years, founded in Rio de Janeiro, also with offices there, in the US, the DRC, Portugal, and working with a range of partners globally. About half of what we do is research, and that research drives our practice in terms of our programs, our policy work, and also our advocacy. And we're rooted in social justice and health equity, and the importance of activism and listening to the voices of communities, and a feminist informed approach to our work. I think one of the key messages I want to make as we begin this conversation is reinforcing what Dominic had said, that manhood and men's understanding of what it means to be a man is important for their approaches to almost every health and violence issue. And we consistently see, we undertake something called the International Men and Gender Equality Survey now in over 36 countries, which is generally a nationally based sample of what's up with men in terms of their understanding of gender equality, their practices, including their use of violence, their engagement in health issues, their involvement in parenting. And we consistently see that kind of hyper-masculinist norms or forms of being a man are associated with a range of risk behaviors that we're interested here, whether it be men's use of physical and sexual violence against their female partner, their perpetration of sexual harassment, their involvement in MNCH and unpaid work and care, their willingness to be supportive of good couple communication around SRH, their ability or willingness to test for HIV, their number of sexual partners, their STI symptoms, their use of condoms, and also substance and alcohol abuse. And we've developed a couple of measurement tools, something called the Gender Equitable Men Scale, that you may have heard of. Also more recently, the Man Box, which you see on the slide there, which is used with 18 to 30-year-olds in the UK, the US, and Mexico to measure the extent to which young men in those settings are in the box of these more traditional masculinities. And I think it's really important just to emphasize that these norms matter. These norms and men's attitudes towards what it means to be a man directly impact on the work that we do, and we need to be cognizant of that and program for it. We've done a lot of work internally identifying what we would regard as the key priority action areas around boys in the context of AYSRH. We had a global consultation meeting earlier this year, which produced a advocacy brief and framing document called Getting to Equal, together with Family Planning 2020. And for us, reflecting on that and the work that we've done over the last 20 years, a couple of areas that are particularly important: the essential nature of gender transformative education, which I'll talk about, the need to work with young fathers as well as young mothers, the importance of targeted SBCC within the context of SRH and family planning, thinking about the life stage specific methods as Dominic talked about, the need to also address men's own needs and concerns within the context of SRH, and then how are we working with young boys as advocates around SRH and to change the narrative and to promote the importance of women's right to choose and to stand up for everybody's sexual reproductive health and rights. I'm going to talk in particular about those areas in red on the slide. One thing I want to underline is the importance, as this document Getting to Equal does, of key principles to our work, and especially the key principle whenever we're working with men or boys around women's rights, autonomy, decision-making and choice must be unequivocal, central and upheld. It's not men speaking for women around SRH, it's men speaking together with and in support of women's SRH. So firstly, just to also add, the Challenge Initiative also have an AYSRH toolkit, as you're probably aware, and it touches on many of these key priority areas, includes evidence-based interventions and many of the tools that are included within this presentation. So firstly, gender transformative education. Our flagship program is a program called Program H, working with young boys. We have now undertaken this for 15 years in over 30 countries, which is a mix of group education with young boys and young women through Program M, combined with youth-led community activism. And it's always informed by local baseline research and then a local adaptation of the curriculum, ensuring that the content speaks to the needs within particular communities. And it's based on evidence of what works. We developed a document together with the World Health Organization over 10 years ago now on the evidence around engaging men for gender equality and health equity. And some of the key things, as Dominic also touched on, were identified within that review, such as the fact that one-off information is not enough, the fact that we need to critically question and be deliberate within that what it means to be a man, the importance of the length of duration of these interventions, that you can't just have a one-off 1 week, and we believe you need at least 10 to 16 sessions. The importance of multiple components, and I want to emphasize that in a couple of places in this presentation, that as you'll see, we're very deliberately combining group education with community-led campaigns and other activities. And that you need to believe that engaging with young men is part of the solution, that men do desire, young men do desire to be more equitable in their lifestyle and in their approach to their partners and in their involvement in SRH, and meeting them where they're at to support them in doing so. So the topics, therefore, cover a range of issues around gender identity and power, sexual reproductive health, caregiving, men's use of violence. We've undertaken a number of quasi-experimental evaluation studies to look at the impact, which has shown that this program has shifted gender norms, has led to reductions in violence, increases in condom use. And we also have 2 randomized control trials of US-based adaptation, which I'll mention in a minute, which are currently ongoing to provide us with more rigorous evidence. Scale up is important to what we do, and in particular, we've been successful in scaling this up through public schools in a number of countries. And we also, in Brazil, we had a teacher training portal specifically dedicated to supporting skills building for teachers around this work. What I would say in terms of lessons of that is the importance, of course, of incentivizing teachers and others to do this. It wasn't a mandatory part of the work in most of those countries. The essential nature of maintaining political will and support for this. We unfortunately no longer have the portal in Brazil that we did to support this work, largely as a result of changes in the political context there. And so how do we ensure that the excellent things that we build are sustained even when there are changes in administrations? Of course, the ongoing challenge of ensuring fidelity to the model, in particular, how do you maintain a gender transformative component when scaled up, as many of us face challenges with? And then how do you make sure that it's not just scaling up in a traditional public health sense, that it's really scaling up so that we're adopting sustainable, activist-led approaches that really do embed within local communities and continue to live on beyond the life of programs. We're also adapting this, and happy to share more when we can for VYAs in Malawi. This is our theory of change for our gender transformative education work. I think want to really emphasize about the importance of, it's not just information and learning, it's really rehearsing these critical reflections, internalizing them, and looking at how you live them out in your everyday life. And of course, supported by the structures, including the institutions, the services, the policies that have to be in place to enable this to happen. That you can't just have standalone educational interventions without broader structures. And if there's time, one of the things that I'll problematize at the end is that so often policies and structures don't speak at all to the importance of engaging with young men within the context of SRH. That structure then enables us to achieve the outcomes that we seek to do within this program. Is not only shifting gender equity and men's understanding of the role of a man, but also increasing condom use, reducing STIs and HIV, reducing violence, and as Dominic also talked about, men's role as agents of change. Thinking again about the importance of multiple components, in Brazil we added on to our program H Group Education an SBCC condom promotion social lifestyle campaign called In the Heat of the Moment, and that was a partnership with Durex Condoms, and in particular it sought to promote gender equitable lifestyles and HIV prevention at the community level through reinforcing the messages that were also being taught through the group education. I think what's particularly important about this is it was young men as peer promoters that were developing the messages, that were implementing the campaign and crafted the messages. So, for example, the Heat of the Moment name came from the fact that young men said that their peers often talked about the fact that men would say yes I know that we should use a condom, but we only use a condom in the heat of the moment. And so really thinking about that as an entry point to have a conversation with young men, and particularly around condom use and the importance of equitable negotiation with their partners as part of a more gender equitable lifestyle. You can see there on the slide that we found increases in gender equitable attitudes and also condom use with primary partners. And I think what's really important here is we need to, and again emphasizing this point, make gender norms and shifting those norms amongst young boys an explicit part of the work that we do. It's not enough just to say we want to promote and engage men in adolescent and youth sexual and reproductive health. I don't believe it's enough just to say, as you want to do in your TCI program, that we need to increase, which is critically important, women's uptake of methods. We really need to think about engaging with men and incorporating a focus as part of our theory of change of how we believe that we're successful on shifting gender norms, that uptake of services and methods cannot be the only outcome in and of itself, given the range of secondary benefits that both Dominic and I are talking about, and the fact that to successfully increase outcomes and uptake methods, we do need to shift these norms, which are proving to be a key barrier to our work for men and for women and for people of all sexual orientation. A word on our US adaptation of Program H. Just really want to highlight that we deliberately, in adapting it for the same age range, 15 to 24 in the US, incorporated a stronger focus on intersectionality and different gendered expressions, especially as Dominic was mentioning, kind of cis, gay, and transgender boys and girls, and also more deliberately focusing on teenage pregnancy, which is a significant challenge within the US, and STI prevention, as well as LGBTI bullying. We, within our work program, P and Manhood 2.0 deliberately try to build in scale up from the outset, and within Manhood 2.0, the scale up strategy was working through local partner organizations. So, for example, in New York, working with an organization called the Young Men's Initiative to embed this approach within their work, and also engaging with the city government. Many of you, I know, don't just work nationally, but you also work kind of regionally and locally. And I think local governments or municipalities can play a key role in supporting the institutionalization of these approaches, embedding this within their schools, within the work that they do across a broader range to reach a greater number of people and to ensure sustainability. And we try to build in those conversations across our work from the outset. I want to shift to our work with parents and young fathers. Program P, as you may have been heard of, is our gender transformative kind of father-centered model for newly expectant parents and parents with young children. It focuses specifically on engaging around reproductive and maternal health and violence prevention. And I think what's important within this is that we see within our work that a key protective factor for violence prevention among young men is having had more equitable parenting within the home, more equitable caregiving and sharing of unpaid work. And we also see that there's a cycle of caregiving, that young boys who say that they witnessed their fathers being more involved in caregiving and unpaid work are more likely within our own analysis to be more engaged as fathers and male caregivers themselves in later life. So it's a cycle of gender equality that this work also promotes. And so you can see here that it focuses on prenatal and postnatal care, the equal division of household labor, positive communication, and to reducing parental and family stress and violence. And it's got three particular components: working with the fathers and their partners in their diversity, working with health professionals also on engaging men, recognizing that the health system, but especially antenatal care, which is a key area of scale up for us within this work, often isn't arranged in a way or isn't the staff haven't been trained to be able to engage with the male fathers. And also community mobilization strategies. It needs to move beyond just the group work itself. So we've rolled this out in multiple countries now, over 10, and as I say, kind of scaled it up, particularly through ministries of health in a number of locations, and have been very successful in particularly, for example, in Chile and elsewhere in shifting policies around antenatal care. And we're now doing some exciting work in Rwanda, which I'll talk about, in Lebanon and Bolivia. This program has also been adapted for youth as well. And I just came back from Uganda last week, where I was in a rural community far away from Kampala, 6 hours drive over the equator. And we were in a school where a school group had used the Program P initiative, particularly around the diversity of caregiving component and the father impact component, to challenge the norms within the school. Really powerful stories of girls standing up talking about the fact that the norms around who cleans the school classroom, who is able to be a school prefect, and who is able in the community to kind of stand up and be heard, were shifting, that women felt much more empowered, but also that there was a ripple effect with these young boys and girls going back to their own homes, challenging the norms around who does the caregiving, who does the unpaid work, but also who's involved in caring for children and sexual reproductive health more broadly. And then we were really humbled by the stories that we heard. And so I think this can really have a generational impact also in terms of shifting those norms. Dominic mentioned Bandabahero. I just want to highlight that we have completed a randomized control trial of Program P in Rwanda. 1,700 fathers, you can see the age range here, and their partners participating in this program. And we're really excited by the impact that we saw, the reductions in intimate partner violence, the reductions in violence against children by both the father and the mother. But importantly also for this conversation, increases in men and women's ANC attendance, increases in reported FP use within the couple, shifts in couple communication, and greater autonomy reported by women in terms of decision making also. And we've had really successful steps with the Rwandan government in scaling up this approach. We've developed a scale-up strategy. The Rwandan government has a technical working group which is dedicated to institutionalizing this approach. And we're excited about where this will lead in terms of embedding this approach and its significant impact across the country. I want to just mention, in the context of addressing young men's own SRH needs, which are as important to this conversation, that as a consultant, I work together with IPPF and UNFPA to develop this global service package for men and boys. And one of the things that in particular it highlights is in detail what are the services that adolescent young men and boys require, as well as older men, and breaks it down in some detail. And I think especially tries to go beyond the more traditional understanding that we have to also think about, what about broader boys' sexual concerns? What about sexual dysfunction? What about the importance of a health check? What about the challenges Dominic mentioned of young men in particular and older men, but young men for this conversation really directly accessing the health system, and how do we get the health system out to them, and what's the range of services that we need to think through that, as well as the building blocks for how you work on men and SRH, with approaches being at the center of those building blocks. Want to just close up with a couple of reflections that beyond SRH, that I think it's really important as we think about this work, and I know that you're focused on within TCI on AYSRH, but that young men and adolescent boys don't see their lives kind of segregated into SRH over here and education and kind of mental health over somewhere else, and that it's really important that we think about the risks and vulnerabilities that young men and adolescent boys face across a range of issues, and how those are both opportunities for us to engage with them, but also create particular challenges as well. So if we think about mental health and substance abuse and the challenge there, if we think about the need for education and the challenges that we face in ensuring that young boys engage sufficiently with education and that it's gender transformative, we think about social media and the ways in which online spaces are used increasingly for abuse of young women and older women, if we think about violence and accidents in workplaces for young men, if we think about the challenge of sexuality in all of its forms, and also sexual violence, and really thinking comprehensively about an approach to young men's health. And we produced this document together with UNFPA some time ago, which is available, looking at adolescent boys and young men's health and vulnerabilities in all of its forms, including SRH. Finally, a word on suicide. 800,000 people take their lives every year globally. The majority of those are young men. We do see a growing global challenge around youth unemployment, social isolation, and we would posit that there is potentially a connection between that. And how do we tap into the challenge of mental health for young men and the impact of this, not just because of the lives that are lost, but also because of the fact that it's generally women and girls who pick up the pieces of suicide and young men's mental health. And I just want to close by saying that, as mentioned earlier, it's not only how we work within communities and individually, it's really the policy structures. And if you look at the world today and the global policy context, such as the UNESCO reports on early and unintended pregnancy and the education sector, or if you look at many of the global important initiatives around young women and girls, Family Planning 2020, we don't have indicators specifically targeting the necessity of engaging with young boys. And I think, if we are really going to be serious about this, if we're going to embed this within
I think we just lost Tim. He was toward the end of his presentation. So something happened, I think, where he lost connection. We'll see if he can make it back on. Let's give him a minute. We're taking the questions now. While we wait for Tim to log back in, I noticed that someone asked a question specifically to Dominic. Maybe we can, oh wait, it looks like Tim's back on. Hi Tim, can you hear us? Okay, hi Tim, are you there?
Hi, can you hear me?
Yes, we can hear you now. Great.
I can close out by just flagging this slide, which I've already mentioned, the framing and advocacy brief, and we have two documents which are forthcoming: a global evidence review on men, gender equality, and SRH, and then a specific national analysis of family planning costs and implementation plans, looking at a range of countries. And this is supported by the Bill and Melinda Gates Foundation, and we'll be pleased to share those with you, particularly if you're coming to the International Conference on Family Planning. We'd love you to be at our reception and discussion on November 13th. Thank you very much.
Wonderful. Thank you so much, Tim. We appreciate it. We've been collecting your questions in the chat box, so I'm going to ask a few. Okay, so I think going in order, Krishna asked a question for Dominic. Dominic, you touched on positive deviance as an approach that is not utilized often and mentioned risk behaviors. But what about protective behaviors under the umbrella of positive deviance? I think we also heard Tim mention this as well. So I'll let maybe Dominic speak first, and then Tim, if you have anything to add.
Yeah, I feel like this is something, as I mentioned earlier, it's something that gets talked about in circles about utilizing positive deviance, and as Krishna mentions, that there are some protective behaviors. One of the challenges that we all, Tim touched upon, and I was trying to emphasize in my last slide, is that balance between, behaviors that have a short-term positive outcome and could potentially be limiting access and choice and things like this over the long haul. So it is a little bit of a tricky situation to kind of dig in and really understand some of those behaviors, but I do think it's something that could be utilized a little bit more. And there are natural things and that occur between father and child that can be emphasized and potentially expanded upon in our work.
I think it's as part of this conversation, I think, there are positive deviances, I think, kind of at multiple levels. So I think, the level that, as Dominic is talking about, to some extent between the kind of at the community level, I think one of the things that we see often is that, in the context of doing caregiving, for example, or, the kind of then connecting that to antenatal care, that, men and young men will say, well, I'm happy to be more involved in the caregiving. I just want to make sure that the curtains are closed, or that people are not going to see me. So I think that it definitely happens within communities, and I think tapping into that and providing more role models that make that acceptable, I think is essential. But I also think there's a disconnect between the reality that many men and boys tell us and the kind of the structures and the approach. And I think both Dominic and I have done research and work on this for a long time. Consistently across my research, men will tell me that they want to be more involved in sexual and reproductive health. That may often be because they want to control it, but I think it often genuinely, for many, it comes from a place of feeling like they don't have the information, they are unaware of where to go, and they feel that the health system kind of doesn't engage with them on this, and I think the national policies and approaches reflect that kind of lack of engagement. So I think how do we tap into that broader desire when we consistently see across our research that men want to be more involved fathers and caregivers, and there are barriers and burdens for them to do so. So I think we need to, as you're saying, Dominic, it needs to be approached from a clear understanding of power and ensuring gender equality and women's rights. But I think there is greater potential to tap into the positive deviance that is there.
Thank you both. Another question that came in. Sorry, I'm going to mute you while I speak. Was specifically for Tim. I believe this was related to program 8 or maybe where does implementation of this model sit with comprehensive sexuality education programming by teachers, or do you have suggestions that would be to revise the toolkit to incorporate GTE? So I think it's with some of these curriculum-based, do you influence the comprehensive sexuality education curriculum and incorporate kind of the programming within that training structure, or does this live parallel? How have you been able to do that and scale it, like you mentioned, in Brazil, I believe?
In Chile, Croatia, India, and Nicaragua, and elsewhere, I think that partly depends on what works best for the local context. So we work through local partner organizations in country who are nationally based partners, apart from our office in Brazil, who then make the decision about together with the school system on what works best. I mean, we do ensure that comprehensive sexuality education is part of the components of the programming, and we definitely don't want to duplicate. And so I think what we often see is that it adds on to and nuances existing content that's already there. I think one of the honest reflections is that often education for young men and young women is woefully inadequate in terms of its focus on gender norms and CSE. I mean, we've been involved with UNESCO in my former life working at IPPF. I was very involved in the promotion of comprehensive sexuality education and creating a framework for that. I think we know globally that we need to do much more on promoting and achieving effective CSE. So I think this has provided an add-on component to that, and particularly I think often teachers struggle, and that was what was very exciting about the training online component that we had for teachers in Brazil, is that teachers struggle with having the confidence and the support to be able to engage, particularly around issues of what does it mean to challenge power, and what does it mean to be thinking about gender roles and kind of more gender equitable behaviors and promoting SRHR. So yeah, I think that it's a more complicated conversation, but I think it's a good point that we need to ensure that we don't duplicate. But I think we are very deliberate in our formative research and our kind of local adaptation processes that we don't do that. But yeah, I think it's a point well made.
Great. Another question that came in was a question on, is the reduction in violence partner and child, or is it reported violence? So I'm guessing that means self-reported, or if it's from the potential victim, maybe is where that question lies.
It's self-reported.
Okay, great.
What I would say is these are of course challenging, and I think what we are particularly proud of is that the range of impacts, and I think this goes to the point around thinking of the different kind of moments and entry places where we can do this work, and and I think we were able with a kind of parenting intervention to not only shift norms around parenting, but to reduce violence in its different forms, and to have an impact on family planning and SRH, and communication between couples, and kind of gender equality, and women's autonomy. And so I think a more rigorous, had there been sufficient resources, would be to ask the recipients themselves. But we do believe that these results are rigorous, and that it does demonstrate a significant reduction in violence against children. And I think the world of violence against children and intimate partner violence and SRH are often kind of separate, and I think it's helpful and important to find ways that we can integrate those approaches together.
Thank you, Tim. And another question that I think can be posed to both are adolescent boys and youth willing to go to see a female health provider to talk about puberty and sexuality? What have that been?
So I don't know if that's really been addressed in any of the projects that I've worked on, in terms of boys' resistance to receiving services. So I can't speak to that. I don't know that it's been systematically looked at, because most of the time when you do the comprehensive sex education into curriculum and things like this, you have one female and one male facilitator, and often who also serve as kind of a liaison between health services and the child and their parents. And so I don't know that that's a good question. I think it's something that needs to be looked into a little bit more. I can say that having worked with adult men, they do like we worked in vasectomy programming and other programming. They do like seeing a male physician most of the time, but I think it depends. I think that's a good question for additional kind of investigation embedded within other research.
Agreed. Yeah, I think in my own research, reflecting what Dominic is saying, often what's most important is the quality of care and the confidentiality and the skills of the provider. And I think often where I've had men saying that they would like to be seen by a man rather than a woman, I think it is a reflection as much of the fact that they feel that the health system doesn't really respond to their needs, and that they feel that it's not particularly confidential, whether they were going for an STI or whether they were accessing SRH or the like. I think what's more important often is ensuring that, as you're saying, Dominic, that actually the services are available, and that there are specific strategies to reach out to adolescent boys within that.
Yeah, I think following up on that too, one place we can look into this topic is Rwanda, where they've gone into some, they've gone to some extremes to incorporate both a male and a female community health worker. And this is a location where, this could potentially be elaborated on in some of the existing programming that is happening in Rwanda right now, or about to happen in Rwanda with the upcoming bilateral. So, yeah, I think it's a great question around boys' access to services, and I think it's an answerable question. and it may depend on sites and possibly even individual characteristics.
So we are at time. So thank you all for your great questions, and a special thank you to both of the speakers. We greatly appreciate your time this morning and the amount of inputs and thought that you put into the presentations, and it's exciting to see the level of evidence-based programming that exists for engaging young boys in AYSRH issues, as well as you've both mentioned, no one just looks at themselves from one lens, so engaging the full person and the lessons that can be learned in engaging more generally to intervene related to gender norms and equality issues. Because we weren't able to get to all the questions, we've started collecting those, and we'll share all the questions with the two speakers and see if we can get additional responses to those and send that out in addition to the recording in the next few days. But I did want to share that if you'd like to keep the conversation going, we've set up a forum on TCI University's website, and here's the link to it. You'll just need to quickly register with the website, I think, to access that group. But we'll make sure to post the questions as well as the presentations there. And as I mentioned, we'll send out an email shortly with all that information as well. Again, thank you all for joining us today, whether it's morning your time, afternoon, or evening. We really appreciate your time, and a special thanks once again to Dominic and Tim. Thanks, everybody. Oh, and the question, when's the next one? We're aiming for a follow-on probably in January or February, given ICFP in November. So